Well, that might be the catch-22, but it's very difficult for the actual patients as well then to see that their neighbours in Leeds are getting treatment, and just because of where they live and because of the primary care trust they've got, they're not actually receiving the treatment. I mean, what do you say to then patients who can't get treatment from the PCT?
When I was Health Secretary, I had to meet a number of patients, not always people whose primary care trust was denying a particular treatment, but people who weren't getting treatment because NICE itself had said, we do not recommend this particular treatment except for a different class of patient.
Well, what do you say then if it does come down to the PCT, if like North Yorkshire and York PCT is saying, no, we won't fund it, but yet Leeds PCT is, what do you say to the patient then?
There is always this tension between national standards and local decision making, and that means that there will be some variation in the care that is offered in different parts of the country, because some places will have different priorities that they will also need to address. Ideally, the funding system, where you've got the most money going to the parts of the country that have got the biggest health problems, will allow every primary care trust to meet the same national standards for something like cancer, for these big life-threatening illnesses. We're not there yet. As I say, I don't think any health service in the world actually is there yet. And I think there's a real issue that still has to be addressed about the accountability of primary care trusts. They're accountable upwards to ministers and to the Department of Health for giving their local people the best in return for the money that they're getting. But there has to be, I think, stronger accountability of those primary care trusts to their local people. So that for me is unfinished business. And these problems you're illustrating, these problems that you're giving the example of, are an illustration of why you need that stronger local accountability.
And of course the reconfiguration was designed to achieve £251 million of efficiency savings. Was that achieved?
My understanding is that it was achieved. Obviously I've been out of the department for the last year, but when I was Health Secretary we were absolutely on track to deliver those savings and put the money where we'd promised it would go, which was in the frontline patient care, which is where you want it.
And yet that year, when they were reconfigured, the NHS went into a deficit.
The NHS was in deficit before the reorganisation took place. And the problem was that although there was a very small deficit, it was set to double each year. And as everybody knows from their own finances, you can overspend one year, but if you keep doubling your overspend, sooner or later you're going to end up having a very nasty conversation with the bank manager. We had to deal with that problem. It was not caused by the PCT reorganisation, and although of course there were costs involved in the reorganisation, and it was very painful for people who lost their jobs, had to find new jobs as a result, it was absolutely the right thing to do.
Well, do we know how much the reorganisation of the PCTs cost?
You'd have to ask the Department of Health for that.
Oh, well, we have asked the Department of Health. They don't actually keep the figures. They told us to speak to the strategic health authorities through the Freedom of Information, and with the exception of one or two, we haven't heard back. I mean, you must have inquired, no, into how much the reorganisation cost.
No, this was something I was obviously dealing with rather closely when I was Health Secretary, and there were significant costs in the year of the reorganisation and the following year, in part because there were people being made redundant and so on. I mean, the costs you'd expect with a reorganisation. Having said that, what was also quite clear coming back from the primary care trusts was that they were saving money, and that was part of restoring the NHS to financial health and making sure that it is giving patients the best value for all that money that's been going in.
But you never got a ballpark figure for how much reorganisation cost?
You're taking me back. I mean, I haven't got the papers with me. But those are questions you'd need to ask the department now, or the strategic health authorities.
But I mean, it's not something that you were particularly interested in to sort of remember getting the figure or asking it for us?
My memory would be uncertain and in any case out of date. So, I'm just not the right person to ask about that, I'm afraid.
Because I don't want to sort of push on the matter too much, but in that year, 1 in 3 PCTs were in debt. The year before, it was about 20%. There were 1 or 2 PCTs, again, mentioning Yorkshire, North Yorkshire and York PCT, still in debt today. And I mean, we spoke to Phil Willis, the local MP for Harrogate, who I think has already spoken to you about this matter on a couple of occasions. And his PCT, he points a finger directly at the reconfiguration.
I haven't actually, at least I'm not certainly aware of up-to-date details about that particular situation. Look, what I think you need to remember is that the NHS was facing, at the time when I was Health Secretary, a pretty serious financial problem. As I say, it was a small one. I used to say it was like somebody on £20,000 a year ending the year with an overdraft of £200, but it was growing in a way that was going to mount up to a very big problem indeed if the NHS didn't get a grip on it. And what we did, and it was very difficult for all the staff across the NHS, but we got a grip on it. And what shocked me in a way was how many people in the NHS thought that I was putting money before the patient. You know, that was the accusation that was always being levied. And I would say, look, you know, you in the NHS keep telling me we're dealing with life and death. It's because you're dealing with life and death that getting the money right is so important, because any money that is wasted is money that you're not spending on the care of some patient who desperately needs it, some Velcade for some gentleman who desperately needs it. That's why value for money and productivity and all that other technical sounding stuff is so important. Fundamentally, it's about saving lives.
For Yorkshire, £16 million was spent on redundancies. The chief executive of the then York and Selby PCT, I believe, you know, walked away with £1 million payoff. I mean, and then at the same time, people are not getting referrals on the patient care that they need. I mean, it's quite a sort of juxtaposition. And then for some of them to then still be in debt and not providing care for their patients.
Well, every organisation faced with redundancies, and they're always horrible, but they do happen, public sector or private sector, has to decide how to treat people who are made redundant.
But £1 million is a bit obscene, isn't it?
£1 million is a very large payoff for somebody who has clearly worked in the NHS for a very long period of time. Otherwise, they wouldn't have been entitled to that sum of money.
Only for 2-3 years, because that's when they were reorganised again. So he wasn't there for that long.
Well, the terms of the redundancy package were all agreed between the Department of Health and, as far as I know, the trade unions. And frustrating though it is, it's actually not something that ministers are directly involved in. And I know that's going to sound like a cop-out. It happens to be the truth. And I do think, particularly
What's your personal opinion?
In the public sector, I think it is particularly important that we treat staff fairly, especially in the very difficult situation of a redundancy. And I'm not going to point the finger at an individual who has served the NHS for years and say, oh, I think you got too much.
So is there then a correlation between the reconfiguration and some PCTs being in debt and patients not receiving their care, like in Phil Willis's constituency?
Well, as far as I'm aware, the financial problems were, in many cases, actually some of them date back even before the primary care trusts were created in the first place, and they're not caused by the reconfiguration. I'm certainly not aware of situations where you could say it was the reconfiguration that caused the problem, and you need to look underneath that to where the problem actually lay. Was it, for instance, a hospital perhaps keeping somebody with a hip fracture in for 30 or 35 days? Which I'm afraid far too many NHS hospitals were doing when the standard of the best was around 9 or 10 days. Dreadful for the patients to be kept in hospital far longer than they need to be, but also a shocking waste of money that was denying care and drugs to people who really needed it. So I would say, look at the underlying causes, and because the way we've reformed the NHS actually makes these things very visible, and gets the hospitals, as well as the primary care trusts, focused on getting the best value for patients, 10 days for a hip fracture on average, not 30, actually we should see every part of the NHS in every part of the country being able to do even better by its patients in future than they're doing at the moment.